Amazing guy. Okay, so let's just look at this right now. So when we're talking about paced rhythms, we're talking about rhythms, okay, where there's an artificial device in their chest that's sending a little electrical impulses to stimulate the heart because obviously their own pacemaker has failed. So these are people probably who have bradycardia, okay, felt weak and dizzy, couldn't lift their heads out of bed, called 911, we took them to the hospital, maybe we had to do something for them, maybe we didn't. In the hospital, the cardiologist came in and decided that they needed an implantable pacemaker, okay? The other way you may see it is that people who have survived VFib get an implantable defibrillator, right? The newer implantable defibrillators actually are a combination of a defibrillator and a pacemaker. Why would that be? Because we said that when the defibrillator does what it's supposed to do, what does it do to the heart? Stops it. And it could be a situation where it stops it and it doesn't start up on its own, so what will the pacemaker do? Try to fire and now start it up. So most of the newer, fancier implantable defibrillators are a combination of a defibrillator and pacemaker. So the interesting thing is that when the pacemaker is working, you're going to see something called the pacemaker spike, because what does the EKG show us? Electrical activity. So the pacemaker is firing, there's electrical activity, okay? So that's the only thing. Now I can't tell you how many times I've looked at rhythms, had people show me rhythms, and you miss the pacemaker spike. Okay, and typically paced rhythms are very wide rhythms because again, what do we have? We have a random electrical impulse hitting some part of the heart, and the impulse has to get propagated across the whole heart. So it's a slow depolarization, you get a wide QRS. Okay, so it's worthy to tell. Now, how do we know somebody has a pacemaker on physical assessment? Typically, the pacemaker is implanted on the left side, not where you would put the AED pad, right, on the left side, and there's a bump on the skin. Okay, so if you see that, they only have a defibrillator or a pacemaker or a combination of both. That would probably be the really only reason why they would have that. Okay, but you know, so that's basic, you know, the situation. What's that?
Seizure, the anti-seizure.
Did they put it in the chest also? Did they? Okay, could be. No, could be. I mean, I saw somebody the other day that has chronic back pain, and the treatment for the chronic back pain was that they actually took electrical wires or probes and put them on his spine. And they basically come to the surface of his skin. He hooks up a little device that sends little electrical impulses, and somehow it tricks the body to register the pain in a different way. So, you know, this guy has another, you know, electrical device. So they want to do it on you too? Did you do it?
I didn't want to do it for the pain in my legs.
Uh-huh.
It's like they want to block the nerve signals. It's like keeping the phone line busy.
Huh. Okay. Okay. So, you know, not that it's a big deal, but we have obviously in the field temporary pacemakers where we can externally pace a patient, okay, by using the same AED pads. And instead of sending a massive shock to the heart, we're sending a low amplitude. It's not, I mean, it doesn't hurt as much as getting defibrillated, but it's not a pleasant, you know, type of thing. But typically those patients are not mentating well, or else you wouldn't be pacing them. So it's, you know, it's, in fact, if they started to complain, you would question the need to pace them, right? Because in other words, if they feel that discomfort, they're probably perfusing their brain enough. So we do external pacing. There's also something called a transvenous pacemaker that they may temporarily put in a patient, okay, in the hospital, where they're actually bringing a wire with a pacemaker down into one of the big veins that goes down to the heart, and they're pacing it that way till they get an actual internal pacemaker put into the patient. And then you have the permanent pacemakers that are eventually going to be placed in the patient. Okay, so again, we have transcutaneous pacing. Okay, most of the times, I usually set it for 60 and 60, a heart rate of 60 and an amperage of 60. Here it is saying to set it at 0 and scroll your way up. You know, what would happen is you would quickly go to 60. In other words, you'd be going 10, 20, 30, nothing would be happening. And usually around 60 is where you get capture, okay, on an adult. Now, what does capture mean? When you turn, let me just go a little ahead. When you turn the pacemaker on, okay, if I set it for 60, you're going to see spikes. Now, these spikes could be downward or upward, okay, just like anything. But you see these extra spikes that are appearing over here? If I set it for 60, you're going to see 60 spikes every minute appear on the screen. Does that mean it's actually generating an electrical complex? Here it is, because I see a spike and a QRS with it. If I just saw a spike with nothing after it, I would say I have electrical activity with no capture. Now, the first capture you want to see is electrical capture. What does electrical capture mean? You see a spike and a complex. The next question is, do I have mechanical capture? And the only way you're going to know mechanical capture is what? Checking a pulse. So you could have a patient that calls you and says, I feel really weak and dizzy. I have a pacemaker, I think it's malfunctioning. And you put them on the monitor, and you see this. And you say, well, no, it looks like your pacemaker is doing wonderful. If you fail to check a pulse and a blood pressure, you're falling for the biggest mistake, which is electrically it looks wonderful, but you don't know that every one of those complexes is actually generating a pulse, therefore keeping an adequate blood pressure. Okay, so remember, you have multiple levels that it has to work on, just like we have situations where we said we could have premature beats that don't actually cause a contraction. Okay, so we have different types of pacemakers. You can have people only have atrial pacemakers. You got people only have ventricular pacemakers. But the most common one is what they call an AV sequential pacemaker, where it paces the atrium first and then the ventricle, just like the heart normally would. So that's the most common one that you're going to see in patients. Okay, and this just tells us that as far as spikes go, what would you see? You see a spike, Pwave, QRS. You'd see no spike in this one between the Pwave and the QRS because it's only pacing the atriums. This one, there would be no spike in front of the Pwave. There would only be a spike in front of the QRS because it's only pacing the ventricles. This one, you're going to have two spikes, spike Pwave, spike QRS. Okay, so just think about what it's pacing, and that's where you're going to see the spike. Okay, so why do people go in it? They have some type of conduction defect, not where it's going too fast. Obviously, if it's going too fast, there's no need to pace them. So it's always going to be something slow. Okay, so typically, you're going to see a spike. So this would be an atrial pacemaker. You got a spike, okay, Pwave, QRS, okay. This would be a ventricular one, no Pwave, or actually maybe there's an occasional Pwave. Remember, the patients could have a working underlying pacemaker that may just fail intermittently, may not work all the time. So they could once in a while be in a normal rhythm and their pacemaker would actually shut off, okay, because these are mostly demand pacemakers. So they'll only pace when they need to pace. So you could have somebody that's in a normal rhythm. So this would be just a ventricular one where you have a spike and then you have a QRS. Now what's interesting about the QRS, very wide, you cannot diagnose a heart attack in a patient on a pacemaker, right? You just no way, because they're going to have these wide, bizarre rhythms. So you really can't, I shouldn't say you can't diagnose, you can't suspect a heart attack based on an EKG in somebody who has a pacemaker. You could still diagnose a heart attack by getting blood work, by taking them to the cath lab and seeing that the blood vessel is blocked, but you can't trust an EKG. So if somebody called you at a pacemaker and said, I'm having chest pain, there would be no way that patient would not go up to the cath lab. They would automatically have to go up to the cath lab because there's no way the cardiologist could say they're not having a heart attack. Okay. And then you have the AV sequential. Now remember I was telling you that sometimes it's hard to see the spikes? You see those little spikes that are hidden over there? Like they're a little hard to see? So for some people, because you got a spike falling real close to a QRS, if you take a real quick glance at it, you may miss it. Again, the machine typically saves our butt, and if it interprets it, it's not going to make a mistake. It's going to say, and it'll actually say AV sequential pacemaker. It'll tell you what type of pacemaker is in there based on the spike. Okay, but here we have a spike, Pwave, spike, QRS. Okay, and that's an AV sequential, pacemaker. So. I just have to call my son for 1 second. He just called me. Hey, so you treated an anaphylactic patient, you didn't even call your father? And it was a girl? Okay. And you're in Woodburn? I didn't ask yet if you were dressed appropriately, so I'm gonna do the rest of the quizzing later. Anyway, I'm in the middle of teaching, so I'll call you back. I can feel he's blushing. It's good. Now he knows there's no place in this earth that's safe from me, that I can know where he is. It's so funny. Okay, so what's the big thing with this? Why are we going to get calls if somebody has a pacemaker put in? Pacemaker's failing, right? There's a problem. There's some type of problem with the pacemaker. Does it happen very often? No. Okay, but it does happen. A wire could slip. There could be some type of issue. Could be somebody was struck in the chest and the wire got dislodged. So, it could be that the pacemaker, just the mechanics of the pacemaker fails. But the biggest problem would be is if you come upon someone who's out on the ground, okay, you put them on the monitor and you see this, and you fail to check for a pulse because you see this and you say, oh, they have a sinus rhythm. You know, they have a normal rhythm. You miss the pacer spikes and you say that they're in a sinus rhythm. Okay, remember, it could be PEA. Okay, it could be that they have a pacemaker that's masking their rhythm. So you can't, you can't say somebody's not dead when when they have a pacemaker, because it could just be the pacemaker that's tricking you into doing it. So it's just very important always to just assess the patient with it. You know, battery failure, they typically change the battery in a pacemaker years before it's ever going to be an issue. These are lithium-ion batteries. You know, they last for a while.
I've run into a number of people in the field where they've run out of money to pay for insurance, and it's been years since it's been looked at by anyone, and now it fails.
Really? That I've not heard of.
I've done 3 or 4 people like that.
Wow, that's pretty sad.
Yeah, it's a molecule.
Well, let's not politicize anything, you know. Guys only got a few months left. Okay. So, yeah. Okay. We had enough today. Hey, did anybody find out why that guy was climbing the Trump building today? Did he have a flag or something he was going to put out?
Flyers in his backpack.
What did it say?
They didn't show because they grabbed him.
Oh, they yanked him off the side of the building?
Literally, they
Oh, is it on video?
They knocked out the window, and as he was trying to move to a corner, to go around the corner, they grabbed him and pulled him in the open window.
I just figured they were going to taser him and then just drag him in.
Saying why he's doing that.
Yeah, he's on his Facebook.
Oh, he wants to talk to Trump?
He wants to talk to Trump.
Okay.
He wants information.
Oh,
He has some special information.
okay. Okay, so I would say battery failure is not an issue, but we've had somebody who's had some situations of battery failure. You know, the runaway pacemaker I've never seen. That would be where a pacemaker actually just overstimulates the heart. That I've never seen. They can dial in, by the way. They can dial into their cardiologist, who can check the settings and actually adjust the settings. So they can actually dial in, and there's actually a way of shutting the pacemaker off and turning the pacemaker on with a magnet in the hospital. So waving a magnet over the patient's chest, the doctor can either shut it off or turn it on. So if you had this runaway pacemaker and this guy's like, you know, going into hyper mode, we can't do it in the field, but in the hospital they could actually, I guess in consultation with the cardiologist, actually shut the pacemaker off by waving a magnet.
It works up to a certain rate though. If it's over a certain rate, the magnet won't work.
Won't shut it off? Oh, then what do? Don't pay the bill when the battery dies. So. Okay, so failure to capture is probably the biggest issue, which means that the machine is trying to send an impulse and the heart is not accepting the impulse, just like it may not accept a normal impulse, right? So it could be the wire slipped, or it could just be, you know, issues with the heart itself. So that could, you know, be one of the issues. Okay, now again, we could have electrical capture, failure for electrical capture, or we could have good electrical capture and failure with mechanical capture. Okay, again, there can be an underlying rhythm. Okay, sometimes the patient may actually have a combination of their normal rhythm and the pacemaker rhythm firing, depending on the heart rate and stuff like that. So, you know, you don't really treat a patient differently with a pacemaker in than you would without a pacemaker. So if they have any kind of arrhythmias and stuff like that, you would usually treat them as normal as you would. And it's just a matter of picking up the pacemaker spikes. Okay, so heart blocks are going to be a little complicated. Let's just talk about it very, very briefly. You have 4 types of these. The heart blocks we're talking about are AV heart blocks. So we established already that the AV node is supposed to slow down the heart rhythm. So obviously, what is an AV heart block? That it's either doing it too much, okay, for too long. It's not doing it. It's never a situation where it's doing it too little. So we have 4 types. We have a first degree, a second degree, okay, second degree type 1, second degree type 2, and a third degree. So we have 2 second degrees, okay, 1 first degree, and so on. So the first degree, very simply, is that the P to R interval, which just shows us the pause at the AV node, is longer than normal. So normally it's about 0.20 seconds. A first degree AV block is longer than it. Most people do not call a first degree AV block an abnormal rhythm anymore. So they would say a patient has a sinus rhythm with a first degree AV block, signifying that the first degree AV block is typically not a symptomatic situation. The patient does not need to be treated or anything like that. And you know, there's nothing really to do for that patient, okay? But then when we start going on to the higher level blocks, it's going to become a little more, you know, worrisome for the patient, or worrisome for us. Okay, so let's skip through the initial stuff, but this would be a first degree AV block, okay? So everything is exactly the same. It's a sinus rhythm, And the only thing that would strike you is that, and then you may not even miss it at first, is that the interval between the start of the Pwave and the start of the QRS, which is the P to R interval, is a little longer than it should normally be. Okay? Nobody's going to call you to the house and tell you, Frank, I feel like I have a first-degree AV block. It's just not going to happen. This, again, is picked up anecdotally to somebody getting a physical, somebody getting called, you get called for something else, and you're just being diligent, you put them on a monitor just to be on the safe side, and you see it. Never gets treated pre-hospitally, probably never gets treated in the hospital. It's just, for some reason, the AV node is holding it for a little longer than it should. Okay, and probably they're going to come back once a year and get an EKG. Just make sure it doesn't progress on to anything higher and stuff like that. So there's nothing really to worry about, nothing really to do on these patients. Could actually happen in young, healthy patients, who have no underlying issues or anything like that. Okay, then we'll go on to the next one. Okay, this is a second-degree AV block. Okay, type 1. It's nicknamed Winky Bach, named after somebody that was called Dr. Winky Bach. Okay, I think he was actually an electrophysiologist. I don't know if he was actually a cardiologist. Okay, and basically what he noticed was that in this situation you have a normal P to R interval, you get a slightly normal P to R interval, you get a slightly longer one, and then all of a sudden you just have a P wave. So you have where the AV node here was doing what it's supposed to do. Here, it was holding it a little longer than it should. It continued to hold it a little longer than this one. And then eventually it held it for so long that what happened? The ventricle never depolarized. When this occurs over 3 or 4 beats, it's very easy to pick out. The problem is when it happens quicker. In other words, where it happens, in other words, this happens over, say, 3 beats or 4 beats. Very easy to pick up. It doesn't have to be that way. Okay, it could happen in 2 beats, and it becomes a little harder because people may say, oh, it's a premature beat or it's not a beat, and get all confused. This really comes down to whether the patient has any symptoms or not, or how slow is the heart rate. And again, it's not necessarily that you're treating the heart rhythm, you're treating how the patient's tolerating the heart rhythm. So if it's too slow, you're really treating a bradycardia. Okay, you're not necessarily specifically having a specific treatment for a second-degree heart block type 1. Okay, so what do we see? We see groups of beats. Okay, so you have to kind of look through it and see groups of beats. And then eventually you're going to find out where you have just a P wave hanging out there with no QRS after it. So everybody's seeing normal, slightly longer, dropped. Normal, slightly longer, dropped. Okay, and again, it doesn't have to be that it's constantly 3 complexes. It can fluctuate, but for teaching purposes, to make it simple, that's what we're showing. Okay, here's another one. Okay, so what do we have here? Normal, little longer, okay, dropped. Normal, little longer, dropped. So here it's over 2 complexes. A little harder to pick out, okay, but it's still second-degree type 1, Winky Bach. I've had patients call, for chest pain and had this. I've had patients call for reasons other than their heart, and you put them on the monitor and you see this and you say to them, did the doctor tell you that you had a normal heart rate? And they say no. So they may have been in it for years for all they know. So you're always treating the patient, not the rhythm, so it just really depends on how they're tolerating and what their complaint is. So what's happening with the AV node here? Remember the first one we said that every beat it's holding a little longer than it should. Here, no rhyme or reason what it's doing, right? The first one it's normal, next one it's holding it a little longer, next one it held it too long, but then it resets itself. So we don't really know why it's doing that, that's what it's doing. That the AV node is a little sticky at times, I guess, as far as letting things through. Okay. Okay, so now we'll go on to the more, dangerous ones. So the second-degree heart block Mobitz 2. Okay, so this is a little more dangerous. So what you're going to see here is you have more P waves than you have QRSs. But when a P wave falls in front of a QRS, there's a constant P to R interval. So that's the best way I could tell you to tell the difference between this one and the more lethal one, which is the third degree. So let's go back. You have more P waves than you have QRSs. But when a P wave falls in front of a QRS, there's a normal P to R interval every time, right? It's constant, I shouldn't say normal, a constant P to R interval every time. So you see that every one of these has a constant P to R interval, but then you actually have P waves that are not out there. So what would you say the AV node is doing? It's letting some through normally, and it's blocking others with no rhyme or reason. Sometimes it falls in patterns, sometimes it doesn't, but with no rhyme or reason, it's blocking certain impulses from getting through. So again, what are we going to be treating this patient for? Bradycardia, lack of perfusion, right? I mean, depending on what that patient's heart rate is, the more P waves you have, the slower the heart rate's going to be. right? Because there's going to be some of those P waves that are not actually conducting. So can you make it out that you just have P waves floating out there with no QRSs? And why is this different than Winky-Bach? We don't see a progression of the P to R intervals with a drop beat. This could be Winky-Bach if this was normal, this had an extended P to R interval, this had an even a longer extended P to R interval, and this was dropped. Then it would be what we just looked at 2 minutes ago, right? But this is not that way. The AV node here is blocking some completely and letting others through. Now the last one, which is the most serious one, oh, whoops, well, let's go. I guess I had a few more I didn't see. Let's see. So, okay, so that's this one. So here's another example of it. So normal, normal. The only thing that might perk our interest here is that it's a little peaked. So we could say it's not sinus, that it's an atrial in origin rhythm. Okay, so we couldn't really call this a sinus rhythm, but we could call this an atrial rhythm. Okay, but again, we have P waves that are floating out there, but the P to R intervals are all pretty constant. So we would call this a second degree, type 2. Okay. Here's a very hard one to diagnose. Normal, dropped. Normal, dropped. Normal, dropped. Normal, dropped. The hardest second degree type 2 to pick up. So it's a 1-to-1. You have one that gets through, one that gets blocked, one that gets through, one that gets blocked. You see that? So this is the normal one. That's actually a P wave that's not conducting. And then you have another one. So you got, it's hidden on the T wave. In other words, this is the downward T wave over here, and this is hidden on it. That is a very commonly misdiagnosed one. Okay, and it does happen. It's not a very common rhythm, but it's not an uncommon rhythm. Now, the worst one is a third degree heart block or complete heart block. Okay. The issue with a complete heart block is that the AV node has now become a wall, and no impulses from the atrium get down to the ventricle. So my question would be, why is the patient not dead if no impulses from the atrium get down to the ventricle? Exactly. The ventricle fires on its own. But why is it such a lethal rhythm? The ventricles firing on their own typically are slow. So it may not just be enough heartbeats a minute to keep the patient functioning. They'll still be alive, but they can't lift their head up. They have to lay down. They feel very dizzy if they sit up. They have what we call orthostatic hypotension, that when they shift their position, they drop their blood pressure. Okay? So what do we see? So here, again, we have more P waves than QRSs like we had in the second degree type 2. But what's the difference? There's no constant P to R intervals. You see the difference? There's no constant P to R intervals. So that's why I went back to my earlier statement. If you have more P waves than QRSs, but you have constant P to R intervals when you do have a P wave in front of a QRS, it's a second degree type 2. If that doesn't happen, it's a third degree heart block. It is not the most scientific one, but I've never been proven wrong. Okay, I've never missed one. I've never been proven wrong. I mean, I'll probably miss one because I can't see well with my glasses, on anymore, but that's the, the issue, okay? Now, the other thing that you could do if you had really good eyes, or if you had those calipers that I showed you in the first class or second class, is if I took a caliper and went from here to here, okay, went from here to here, from here to here, here to here, my atrial rhythm is regular. The thing that confuses you is that sometimes the P wave actually falls on, T wave falls on the QRS and it gets hidden. Because why is that happening? Because the atrium's firing all on its own, thinking everything's wonderful, has no idea that the AV node is blocking it, so it's firing like it should, and the ventricles are saying, okay, no stimulation from up above, so I'll fire. And they're firing all on their own. So you have two separate conduction systems that are firing, and there's going to be the odds that occasionally they're going to overlap. And that's what you're having here. So if you looked at this T wave / whatever we're going to call it, P wave, it's much higher amplitude than this one. Why? Because you have two things occurring simultaneously. The same thing like if you mapped out your R to Rs. You got one here, here. If you had calipers that stretch that wide, you would see that your R to Rs are regular. Why? The ventricles have no idea the atrium are firing, so they're firing at a regular basis. So a complete heart block, by definition, okay, has regular P to Ps and regular R to Rs. Everybody understands what the P to Ps, right? The P waves are regular and the R waves are regular, but there's no coordination between the atrium and the ventricles. How do we see that? The lack of coordination, that there's no P waves falling in front of a QRS, causing that QRS to depolarize.
Why isn't the QRS wider?
That's a good question. And that's a very good point, most third degree heart blocks have a wide QRS, and the likelihood of that patient going into complete heart block, where you just see P waves going through the screen with no QRSs, which means death, is much higher when they have a wide QRS, because it shows you, the wider the QRS shows you how far down the conduction system the pacemaker had to wait till it started to fire. So that's a great question. So really, having this rhythm with that narrow QRS is not typical of a third-degree heart block. But if any one of us had to be in a third-degree heart block, this would be the one we'd want to be in, because it's got a narrow QRS. It's better. It's a safer one. What's that? It's always going to be Brady, yes, because the intrinsic rate of the ventricles is typically under 50, right, for 20 to 40. So they're always going to be bradycardic. They have to put a pace. Well, emergently in the field, you could try to give them a drug called atropine. Okay, it probably will not work. Okay, or you could try to externally pace them. But really, it would be in the hospital, they would quickly put in a transvenous pacemaker, and then the cardiologist would have to, interventional cardiologist would have to come in and put in a regular implantable pacemaker in the patient. So they at this point will have to have a artificial pacemaker. This will not last, for days. They would have to, they would have to have something put in there, and their perfusion would be so low, they're not going to sit up. Their blood pressure will be so low they'll pass out. Okay, so this would probably be a little more typical of what Jack is saying as far as the wide QRS. So what do we have? Okay, we have more P waves than we have QRSs, no constant P-to-R intervals with a wide QRS, and a much slower heart rate. Okay, much slower. So this is the more typical third-degree heart block, the more unstable patient. Again, if we mapped out the P to Ps, they actually probably are falling pretty regularly. Like we probably have one hidden here, another one hidden here. So the P waves are probably falling pretty regularly, okay? And the QRSs are also going to be falling, pretty regularly. So this would be, and the worst thing that could happen in a patient with third-degree heart block is that the ventricles just don't fire anymore. So what you would basically see is just P waves going across the screen, okay? They call it ventricular standstill. The ventricles no longer decide to be the backup pacemaker, and within 2 minutes, 3 minutes, they're going to be asystolic. I mean, they're dead immediately because there's no ventricular contraction, but in a couple of minutes, there'll be no more atrial contraction because the pacemaker will be deprived of oxygen and it will no longer fire. So that's what will happen if you have somebody in a complete heart block and you're treating them, rushing them to the hospital, and they become unresponsive. You'll probably come over and just see P waves going across the screen. And it just means the ventricles just decided not to be the backup pacemaker anymore, and they're not functioning anymore. Okay, so here's probably a better, complete heart block, a narrow QRS. But what do we have? P wave, P wave, P wave, P wave, P wave, P wave, all over the place. Okay, no constant P-to-R intervals. Okay, R to R's are constant, P to P's are constant if you were able to pick them out and map them out. So this would be, again, another third-degree heart block, just with the trickier, and it does happen once in a while that they have a narrow QRS. It's just a better version of it than one with a wide QRS. Okay, treatment would be exactly the same. Okay, so what do we do? First-degree heart block, nothing to really do. Most people don't really call it a abnormal rhythm. It's of little or no significance. Nothing really to do for the patient and stuff like that. If it does happen in the setting of somebody having a heart attack, it probably is a heart attack that involved the septal wall. The septal wall is the wall between the left and right side of the heart. What runs through your septal wall? Your cardiac conduction system. So if you have a septal wall infarct, you're very susceptible to having heart blocks. So if it happened in the setting of a septal wall infarct, what do you think they do automatically? Put a pacemaker in. They won't fool around. They will automatically pretty much put a pacemaker in that patient, because they don't want in the middle of the night this patient goes from a first degree to a third degree while they're sleeping and nobody's watching them because they shut off all the alarms, that we were talking about before, and they don't notice the patient got bradycardic. Okay, so that might be, so most people that get a pacemaker post-MI, post-heart attack, are septal wall infarcts. Okay, not a common infarct, but it can happen. Okay, second degree type 2, Winkie-Bach, we said is what? That we're going to have a normal P-to-R interval, a slightly wider P-to-R interval, a slightly wider P-to-R interval, and then we're just going to have a P wave hanging out there. Okay, doesn't have to happen over 4 beats. We said it's hardest to diagnose when it's less beats because we don't see that progression of the increase in the P-to-R interval. Again, for the most part, they're pretty much asymptomatic. Okay, but there's always a possibility that it can progress onto a second degree type 2. This is second degree type 1. It can progress onto a second degree type 2 where they're more likely to be unstable, and a second-degree type 2 could always progress on to a third-degree heart block. Okay? I have not ever had a patient that's been in this rhythm that has progressed on in the setting, that the few minutes we're with them, but I'm sure it's possible for it to happen. Okay? And then we have the second-degree type 2, okay? And there we said we have more P waves than QRSs, but when a P wave falls in front of a QRS, we have constant P to R intervals, right? So here, what is the AV node doing? It's blocking some, but it's letting others through. The one that it lets through is the one that has the normal and constant P to R interval. And then the worst one is we have a third degree where there is no more AV node letting anything through. The AV node becomes a block, a wall, doesn't let anything through. So you got the atrium firing regularly, probably at a normal rate. You have the ventricles firing at a slower rate, but regularly. There's no constant P to R intervals. Okay? So that would basically be all of them. So let's just go back and look at them real quick, and then I'll let you go, because I know it's been a long night. Okay, so we said the first degree, all it is a what? Prolonged P to R interval, right? So from the beginning of the P wave to the beginning of the R wave is greater than 0.20 seconds, which is 5 little baby blocks. Okay? So no symptomatic, no treatment, nothing you really have to worry about. Then we add a second degree type 1, okay, Winky Bach, where it tends to fall in patterns. So you have a normal P to R interval, a slightly longer P to R interval, a slightly longer P to R interval, and then you just get a P wave that's floating out there. The AV node is progressively holding on to it, each one a little longer, and it holds on to one for so long that it doesn't actually cause conduction of the ventricles, and that's why you only have the P wave. This patient may call you because they feel like their heart rate's a little irregular, okay, but most of the times there's nothing that we really have to do to treat this patient, okay? Here's it again happening in a shorter period, so instead of happening over 3 beats, it's only happening over, 2, so it's a little harder to pick up, but P wave, okay, slightly longer P to R interval, and then you just have a dropped P wave, okay? So just a little harder to pick up, okay? P wave, okay? Oh, I'm sorry, this is in the second, now we're going to second degree Mobitz 1. So here, no, this is still Winky Bach. So this is just a leftover one, okay? So here we have a slightly progressive, just P wave dropped out. So normal, okay, slightly wider, P wave dropped out, okay? Actually, no, I'm sorry, here's the P wave dropped out. So normal, wider, really wide, and then just a P wave with no QRS, okay? So that's pretty, that's probably a patient with a pretty slow heart rate. What do you have? 1, 2, 3, 4, so maybe 40 to 50, heart rate. So 1, 2, 3 would be over here, so that's probably a heart rate about 50. Okay, and then we have the second degree type 2. Okay, so here we have more P waves than QRSs, but when a P wave falls in front of a QRS, there's constant P to R intervals. So that's showing us that there's still some connection between the atrium and the ventricles. Okay, the ones that are conducting are the ones that are getting through normally, and then the P waves that are out there without the QRSs are the ones that are being blocked. Okay, same thing on this one. Okay, P wave normal, P waves without QRSs, but we have constant. Where it does happen, where P wave is in front of a QRS, we have constant P to R intervals. So that would be a second degree type 2. Okay, again, a little harder now because it's only happening over 2 beats, but normal. And then you just have a P wave that's hanging out there. Normal P wave that's hanging out there. Okay, this patient may not even know there's anything really going on because the heart rate's so fast, or they may not even be, symptomatic. I've never in my life saw a patient in a second degree type 2 this fast. It's typically slower. So this might just be, something textbook-wise. And then the last one is a third degree, okay, heart block. And here, again, we have more P waves than QRSs, but what's different than the other one? No constant, what? P to R intervals, right? So here the AV node has become a complete block, a complete wall, not letting any through. So the atriums are going to be firing regularly because they don't know that occurred. And the ventricles are going to hopefully pick up as the backup pacemaker, and they're going to be firing regularly. But again, when you have a P wave in front of a QRS, you'll see no constant P to R intervals. And if you really had time, you could map out the P to Ps, they would be regular, and you could map out the R to Rs, and they would be regular. So, and this would be probably the most symptomatic one. Out of all of the ones we looked at, the one with the wide QRS would be the most symptomatic of all of those. Okay, so I know I rushed through tonight. I don't know what we want to do. if there's, I guess I'll send out an email if anybody wants to come back for one more time and do like a whole total review from the beginning, we could do it. If not, thank you very much for coming. I know it was a lot of material in 6 or 7 hours and stuff like that. I hope you got a little bit out of it. So I'll send out an email. We'll hopefully get the videos up there, shortly as a review and stuff like that. And obviously, if anybody has any questions, you could always email me or call me. Okay, everybody have a good rest of the summer. And if we see each other, okay, thank you.